Hi, welcome to another episode of 4D Dialogues in a detailed discussion and dialogues in Indian diabetes. Today we will be covering our 23rd episode. We're in version 2, and it is very exciting concept that we are going to be discussing today. We'll be talking about body weight and the risk of CVD and diabetes because of body weight. And today we have with us Dr. Anusha Handral, renowned and right person to be talking about this topic. She has various publications and in Indian as well as international journals. She's been a prolific speaker in many forums all over the country. She's won gold medals in poster presentations, and she is also the third prize winner in the ISBMR quiz. So she definitely has a interest in bone and mineral research as well as in obesity. She is a member of Endocrine Society, Thyroid Society, and she is the right person for us to be discussing this topic. And excited to hear her views today.
Thank you so much, Abhijit sir, for those kind introduction words. Good evening, everyone. So today we'll be largely discussing about body weight, how body weight is a risk factor for diabetes and having a cardiovascular disease. So India, I think, is the epicenter for obesity, right? We have huge increase in incidence and prevalence of obesity currently in India. It's actually a complex condition of increased subcutaneous as well as visceral adiposity associated with adipose dysfunction and insulin resistance, which ultimately increases the risk of having diabetes and cardiovascular disease. We see that there is huge increase incidence of obesity both in urban and rural population in India. The prevalence of abdominal obesity was found to be around 40% in women and 12% in men. Definitely, the numbers are much higher. Study shows that 5 to 6 out of 10 women between the age groups of 30 to 49 are abdominally obese. The association of abdominal obesity in women is stronger with older age groups, urban residents, wealthier sections, as well as somebody who is consuming non-vegetarian. Though in this discussion here in this slide, we are saying 73% of urban Indians are overweight. Definitely, obesity is also picking up in rural areas. Likely that we are missing out because there's no good data collection, there's no good database in rural areas. Without doubt, we are seeing a lot of obese individuals, especially abdominal obesity, in patients in rural areas as well. Right, almost half of the urban Indians are obese, is what has been studied in this following publication. Now, Indians are at increased biological risk for cardiovascular disease because of multiple factors. One, that is obesity. Second, what they've understood is because of population level changes, right? What has happened is over a period of time, we Indians are having huge change in the lifestyle, right? We are having easy access to unhealthy food, right? Our carbohydrate content is very high, our protein portions is low, our fiber portions is low. We are eating a lot of fats, unhealthy fats, trans fats, right? Our lifestyle is poor. We are not able to exercise. Diet is not taken care. Exercise is not taken care. We are under a huge stress, maybe work stress or familial stress. Along with that, genetic mutations, right? Hereditary and genetic mutations that is increased biological risk together increases the risk of we having obesity. Obesity is one of the definite risk factor for having a cardiovascular event, right? Amongst the various other cardiovascular risk factors like hypertension, diabetes, cholesterol abnormalities, having high LDL cholesterol, high triglyceride, having decreased HDL, smoking, sedentary lifestyle, being overweight and obese, these are majority CV risk factors, right? It is important to know that all these risk factors, right, are all because of obesity. Now, when you're obese, most of obese individuals will have high risk of having diabetes, high risk of having hypertension, high risk of having abnormal cholesterol profile, right? So sometimes these people are depressed, they get into addictions, they consume excess alcohol that can lead to aggravating the fatty liver. Already there is a metabolic liver disease there, right? MAFLD is there. Along with that, there is alcohol, so the chronic liver disease onset happens, right? So there are multiple factors which can ultimately lead to having a poor quality of life. So let us try to understand what is the epidemiology of diabetes. In India, around 77 million people above the ages of 18 years are suffering from type 2 diabetes, and a good number are pre-diabetic, who are at higher risk of having developing diabetes in the near future. Though we have given 25 million, the numbers will be definitely high because pre-diabetes is largely underreported in India. Adults with diabetes have a 2 to 3 fold increased risk of having heart attack as well as strokes. Now, this is a beautiful study which has been published in Diabetes Care in 2023. Uh, Important thing is it emphasizes how obesity, diabetes together increase the risk of CVD. Right? This is a UK Biobank cohort study where around 4 lakh 51 patients were incorporated in the study. Right? Various graphs here show that as a patient's BMI increases from normal to obese, right, his risk of having cardiovascular disease increases, and the risk becomes additive if a patient has diabetes as well, right? Few studies which have looked into a calculate interval medial thickness. Again, obese individuals as well as diabetic individuals have an additive risk. They have decreased left ventricular ejection fraction. They've also looked into a cardiac contractility index, which is poor in patients who are diabetic as well as obese patients. Now, what is the common soil for all of these? As we all know, metabolic syndrome, insulin resistance, obesity, diabetes, and cardiovascular disease are, one thing leading on to another one. So, what exactly obesity does to insulin resistance? Now, whenever we have excess adipose tissue, this releases a lot of adipokines, which incites inflammatory pathways. Right? Whenever there is inflammation, there's a lot of inflammatory molecules which are released, which can actually cause insulin resistance. Now, many a times, this adipose tissue also releases free fatty acids. They actually impair the oxidative mechanisms, right? Along with that, there is associated mitochondrial dysfunction which happens in these individuals. And there is huge accumulation of lipid derivatives, which will cause lipotoxicity. Along with glucotoxicity, there is increase in insulin resistance, and that's the common soil for having onset of diabetes, right? So this entire mechanism gets aggravated if patient is taking excess lipids, excess carbohydrates, is being inactive, is being immobile, and definitely other chronic diseases can aggravate this condition. Definitely aging. As the person ages, we see that there is progressive beta cell dysfunction along with insulin resistance going on the higher side as well. So, what exactly happens in insulin resistance, which leads on to type 2 diabetes and CVD, is whenever there is insulin resistance, there is hyperinsulinemia, excess insulin release, which activates MAP kinase pathway, which ultimately results in accelerated atherosclerosis. So there is a decreased vasodilatation, right? There is increased inflammation, right? There is decreased oxidant mechanism, right? Antioxidants are not working well, right? There is decreased release of nitric oxide. There is increase in deposition of cholesterol and other products in the blood circulation, blood vasculature as well, leading on to formation of atherosclerosis. Over and above, there can be a platelet deposition and formation of a plaque, atherosclerotic plaque. Once it becomes unstable, it can throw a embolus, right? And sometimes this can also lead to coronary artery disease. And definitely, we should also understand that there is impaired PI3 kinase signaling pathway, impaired muscle glucose uptake, and impaired suppression of glucose production. That is, uninhibited release of glucose from the hepatic circulation, right? So that's why we see a lot of patients having increased fasting blood glucose levels. This will ultimately lead to development of type 2 diabetes, which can again continue to worsen. We also have a lot of other molecules which are implicated, cytokines, inflammatory molecules, age products, right? All of it, AGE products, advanced glycation products, which can ultimately result in worsening of insulin resistance as well as can sow a seed for having a cardiovascular event. Now, how do we prevent, right? So nowadays we're calling obesity and type 2 as syndemic or pandemic of two things. Okay, India is currently struggling with obesity. How we can counsel our patients? First and foremost, give a good counseling. It is important that they know that they're doing is wrong. Okay, so we should tell them to limit unhealthy food. Okay, avoid ordering food from outside. Try eating as much as home cooked food. Try reducing your oil in the diet. Try reducing your carbohydrate. Right. Ask them to cut down on the carbs and extra sugars, refined sugars, and ask them to replace with proteins and increase fibers in form of vegetables. Right. Fruits also is a good thing, but definitely not excess of fruits, as we all now know that fructose also causes fructose toxicity similar to glucotoxicity and can worsen insulin resistance, right? Ask them to take a good amount of fibers in the diet, right? Each meal should include good proteins and fibers. Ask them to be physically active. Okay, I always tell patients, right, if you're not able to exercise, at least reduce the sedentary activity, right? Half an hour of monotonous sitting in front of the computer can be broken easily. 5 minutes they can come out and take a fresh walk and then come back and continue the job, right? Any form of physical activity is okay, be it sometimes simple as walking. They can go with a treadmill or a cycling or a zumba or yoga, meditation. All these are very important. Definitely avoid the screen, right? I think most of us are glued to the screen these days, be it computers, mobiles. So limiting television time or screen time is extremely important, right? And definitely improving sleep and reducing stress, right? At least sleep 7 to 8 hours per day, and as much as possible reduce stress. To break down the stress related issues, try to do some meditation, yoga at least 15 to 20 minutes per day, right? And now, once you have type 2 diabetes, along with lifestyle changes, you should keep a account of body weight and at least 30 minutes of moderate kind of exercise each day, right? 5 days per week at least is minimum recommended, right? Again, eat healthy diet and avoid sugar and definitely saturated fats, trans fats, right, which is easily there in all the packeted fried items, right? There's huge trans fats in all these items, so avoid the easy available foods like chips and biscuits, which have refined flour, as well as they have saturated fatty oil there. We will always recommend patients avoid tobacco and smoking, because smoking itself is definitely a cardiovascular risk factor, right? It suppresses the antioxidant mechanisms and increase the free radicals in the blood circulation, which will ultimately result in forming the atherosclerotic plaque. Now, coming on to when a patient has cardiovascular disease, again, the same thing holds good, right? And definitely, we should make sure that the blood pressure, blood lipids, and blood glucose levels are controlled. Now, important to note that is type 2 diabetes patient, whenever we are seeing, it's just not about control of blood glucose levels. We need to have a holistic approach in identifying which are the problems he's having. Like in case if he's recording high blood pressure, we should give him a good blood pressure control, number one. Number two, in case if he has a deranged lipids, we should advise him good diet and exercise, as well as add some medicines including statins and fenofibrate to get his LDL cholesterol and triglycerides down. We should encourage him to do smoking cessation. If required, we can have a psychiatrist involved to use medications which will help in weaning off smoking, right? And definitely discuss about exercise and make sure that we give them a good A1C. A1C less than 7% is very much required for most diabetic individuals to prevent onset of micro and macrovascular complications, right? We have had studies like 16 trial, which has looked into diabetic patients where all the risk factors were taken care, right? When they were asked to exercise, when they were asked to take care of blood pressure, when cholesterol was treated well, the risk of micro and macrovascular complications were much lesser. This was a STENO trial which looked into 10 years follow-up for all diabetic individuals. Now, what are the therapeutic strategies we have for weight management? For short-term use, we have phentermine and diethylpropion. Again, this most of us are not using these days. Now, for approved for long-term use, we're using orlistat definitely. A few clinicians do use topiramate. bupropion, naltrexone also, but I don't have personal experience with these molecules. Have been using orlistat, and now it's the era of GLP-1 analogs. These GLP-1 analogs do control blood glucose levels in a very good way. We've got even reduction up to 1.5% in most individuals when we use the full dose of GLP-1 analogs. So I routinely prescribe orlistat, liraglutide, semaglutide for most patients who would want to lose weight. So again, choosing anti-hyperglycemic agents. Always try to use combination to enhance preservation of beta cell function. We also encourage clinicians to use newer medications like DP4 inhibitors, sitagliptin, linagliptin, alogliptin, vildagliptin. We also encourage them to use SGLT2 inhibitors. We know canagliflozin, dapagliflozin, and empagliflozin through the various CVOT trials have proved beyond doubt that using these molecules have reduced the risk for having a coronary artery disease. Definitely the incidence of CVA were also seen to be on the lower side. The risk of heart failure is also much lesser. Hospitalization heart failure risk is also much lesser when SGLT2 inhibitors are introduced in treatment of diabetic patients. We also know that now in heart failure protocol also SGLT2 inhibitors have taken a hand. It is one of the medicines which is used in treatment of heart failure. Now, GLP-1 analogs have come into the market in the last decade. We had earlier injectable forms. Now we have oral forms as well. They regulate and restore the incretin function. They have two important properties. One is a very good A1C reduction. Second, they cause good amount of weight loss, right? This will reduce the insulin resistance as well. Now, coming on to discussion with heart failure with reduced ejection fraction, according to various international authorities, including AHA, American Cardiology Association, they recommend dapagliflozin 10 milligram once daily. Empagliflozin we can start with 10 milligram and go up to directly 25 milligram once daily. So, effect of SGLT2 inhibitors for treatment of type 2 diabetic patients in patients with heart failure with preserved ejection fraction also is there, or in patients with reduced ejection fraction. So, both set of patients you can definitely use these molecules, right? So, what they do is they act on multiple pathways. One of that is they cause glucosuria. The volume overload comes down to a good extent. They definitely handle the oxidative stress and inflammation. They reduce the fibrosis and hypertrophy of myocardial musculature, right? So the heart is able to pump much better, right? So it improves the diastolic dysfunction. So it has been studied that when patients are on SGLT2 inhibitors, that when compared to somebody who was not on SGLT2 inhibitors, had a higher risk of having a coronary artery disease as well as heart failure. Now let us go into this study, which was published in Diabetes Care in 2015. This is a 24-week international multicentric randomized double-blinded parallel group placebo-controlled phase 3B study. Here they looked into A1C and fasting plasma glucose, actually significantly improved from baseline with dapagliflozin. More patients achieved a therapeutic glycemic response with the use of SGLT. Body weight and systemic blood pressure were significantly reduced from baseline over 24 and 8 weeks respectively with dapagliflozin. So now we've got a lot of combination molecules in the market. The utility of combination molecules is number one. What we are happy about it is each molecule will have action on one or maybe two or three of famous omnius octet of diabetic pathogenesis, right? So they may act on, some of them may act on kidneys, pancreas, liver. So they have multiple, and some of them act on also on adipose tissue as well. So when you combine two, three diabetic medications together and give it to the patient, the A1C reduction is quite significant because we are attacking multiple pathways. So advantages of combination are they improve both insulin resistance as well as functioning of beta cells. It is seen when combination medicine is given to patients, the initiation of insulin slightly gets delayed. That is important, right? The treatment failure is also delayed. Okay, and it is safe, rapid, and it gives us a sustained glycemic control. Now, newer molecules like SGLT and GLP-1 analogs help in body weight and blood pressure reduction. the patient becomes more compliant because it reduces the pill burden. It's cost effective, right? Once the combination medicines are in the market, it definitely reduces the cost and reduces the pill burden. Now, we see that GLP-1 analogs are also good molecules, but only thing is that in India, the cost is a difficult thing. Next is many people have a lot of acid peptic disease. They have GERD problems, which can get aggravated with GLP-1 analogs. So wiser is to start on SGLT2 inhibitors and DDP4 inhibitor combination, and then upgrade it to like GLP-1 analogs if the patient is able to tolerate. So what other things the SGLT2 inhibitors can do? Right? They inhibit the renal glucose absorption. They cause a good glucosuria. They can independently reduce the blood pressure, systolic blood pressure anywhere from 4 to 6 millimeter mercury. They can decrease the diastolic blood pressure anywhere from 1 to 2 millimeters mercury. Important to note that there is lower risk of hypoglycemia. Now, coming on to DDP4 inhibitors, they've been in use in market for almost more than a decade. They increase the lifespan of incretins which are available in our blood circulation, right, by inhibiting DDP4 enzyme. Important to note that they are weight neutral and definitely there is lower risk of hypoglycemia. In situations, they also inhibit the glucose secretion from alpha cells to protect us from hypoglycemia. I think we're almost ending with the discussion. Final conclusion. I would always, emphasize on weight reduction for all diabetic individuals. Weight reduction actually gets their blood glucose levels down, reduces the insulin resistance, takes care of their metabolic associated liver disease, reduces the sleep apnea, right? Many people have relief in osteoarthritis symptoms once they reduce weight, right? Their blood pressure comes down, they have a favorable lipid profile, they have a good quality of life, right? And there will be definitely reduced risk of having the cardiovascular complications with weight reduction.
Thank you so much, Dr. Anushka. I think you've highlighted the important points when we are looking at diabetes as a challenge. I think you have clearly stated that we are dealing with kind of pandemic type of a proportion of challenge that we face in our country. My my first question, I'll ask a few questions and I'm going to end it with a googly question. So be ready with a tricky question in the end, madam. So the first question, I think there, when you look at the the number of genes that are involved with regard to obesity, and why I talk about the genetic factor which plays a large part. I think if you look at just taking low birth weight babies and the risk of obesity in these individuals, and the journey of obesity from childhood to adulthood, at what stage it starts. I think it's very important, taking a proper history when we are assessing our cases. So can you add a few points about talking about history taking when we are assessing an obesity case?
Very important question, sir. Very apt. We all know that most of SGA babies, small for gestation age babies, have in utero insulin resistance, right? And whenever such kids, catch up weight during adolescent period, they are at higher risk of growing into kind of obesity as well as have higher risk of having diabetes and cardiovascular disease. There are few studies which have beautifully looked into two, three sets of patients. They followed up one patient, maybe a child who was obese, who continued to be obese. This obese child was normal birth weight or increased birth weight, macrosomia, and they were followed up. There was certain amount of increased diabetes risk and cardiovascular disease. Another arm where they looked into somebody who was IUGR, and these children gained weight during adolescent period. They compared these two set of patients. Another group, what they did was they looked into somebody who remained lean throughout, being born as SGA, being lean. These two groups actually, for a surprise, had a higher risk of having diabetes than the other group. So this was one of the data which was published. It is interesting to know that just not being obese, you being lean or being SGA and then gaining weight during adolescent period pushes you to have higher risk of cardiovascular event as well as diabetes, because there's in utero programming which happens, which already would have aggravated the insulin resistance pathway.
So excellent point you bring up. So I think just to follow up on this point, Now you look at high risk cases, and how we are now talking about obesity and measuring obesity. We just look at body weight, we look at waist circumference, and kind of we like, yeah, yeah, everything is okay. But we are kind of missing out on this subclinical level, uh, that these individuals who are harboring this visceral fat that is there, again, it is not clinically seen, nor is it biochemically we are able to pick out any of these points yet. And I think that is where we need to be putting our focus. And back to the same clinical scenario, how aggressive should we do you feel we should be in an individual? Because most of us will have normal body weight if you look at it, but we are harboring this visceral fat that is there. So at what stage do I start to, like, say, look, we need to attack this is what is going to lead to a big challenge? So how would you handle such a scenario in your clinical setting to motivate your patients to get on the path of uh, it is like not just looking at this weighing scale, but looking at the whole body per se.
Yes, sir. That's a very important thing. Whenever we measure the BMI, if somebody who is a good runner, who is an athlete, the BMI will give us a false idea, right? There'll be a lot of muscle weight as well, right? Those situations, just measuring abdominal obesity will not really guarantee anything to us, uh, because there's a lot of visceral adipose tissue in most individuals. First thing is, we are not sure BMI is an accurate measurement of body fat, because if somebody is an athlete, there is a lot of protein mass in them, right? Muscle mass, the lean mass, what we call. Number second is, only measuring abdominal obesity will not help, right? We don't have any effective measures for measuring visceral adipose tissue. Though we have BMD DEXA scan, but it cannot be there in each and every center. Again, the cost of BMD DEXA assessment of visceral adipose tissue will be there a problem. We do not have standards to say this is high, this is low. We only say that visceral adipose tissue is there, but we do not have clear-cut criteria. What is higher visceral adipose tissue? And many a times, even the visceral adipose tissue may not be that high, but it may be quite problematic. It may be releasing a lot of inflammatory molecules, even though the levels may be low. It may be releasing a lot of molecules. So, in a way, it is very difficult to objectively say that who is obese, right? And if a patient is not obese, if he's lean, does it really qualify him not having a cardiovascular disease? Because we are not sure about his visceral adipose tissue. And now, a lot of studies have also looked into muscle fats. Even intramuscular fat is known to be atherogenic these days, right? So this is something which has latestly come up. So each and every visit, we need to emphasize on weight reduction for our patient. Even though they're lean, if they're diabetic, they have to follow good diet and exercise, restricted calorie intake, increase the protein, increase the fiber portion, reduce the carbohydrate content in the diet needs to be emphasized. And also, whenever we are treating pregnant mothers, definitely we should make sure that their diabetes is taken care, right? As well as, we have seen a lot of patients, mothers who are diabetic. A few set of children have become diabetic, they're macrosomic. So that will again increase the risk of they going on to obesity even in youth and adulthood, and increase risk of cardiovascular disease. And make sure that the birth weight is okay. All the risk factors, if they have APH, if they have other risk factors, that needs to be treated by the gynecologist, so that we have a normal birth weight, right? That's number one. Number two, emphasize reduce screen time. Most of the children, are glued to the screen, either mobile or TV. Ask them to be physically active. Engage them in some sports, outdoor activities, at least 1.5 hour per day, right? So they should be involved in some sports, and avoiding the junk food or easy processed food needs to be done, right? So the counseling should start right from childhood, so that they can adopt dietary practices and continue throughout youthhood and adulthood.
Excellent point, madam. I think when you look at post pregnancy, the number of cases, they used to tell me. I mean, when you're taking the history, they said pre pregnancy this was my weight, post pregnancy it just things start to go downhill, because it, again, being motherhood is a huge challenge. If the support is not there, the lady is dealing with a lot. And I think as treating doctors, we need to emphasize of good health nutrition at every stage in life, again, in childhood, as you mentioned, and in special cases, again, post pregnancy, postpartum. I think we need to be really aggressive post any illness. you again see the levels of weight going up. So we need to be constantly talking about this to our patients, tracking their not just the body weight but also assessing other parameters in order for us to make a difference to our to our patients when we are fighting this challenge. So now the trick question, madam, we almost come to the end of the program. So in this 10 days, how many meals did you cheat on, or how many meals did you overeat?
Yes.
Well,
See, though we
constantly.
Yeah, though we advise many times to our patients, I think we as clinicians also, I think many of us, including me, we also do cheat on meals, right? So we also have to take care of our lifestyle. We also have to exercise. We have to do some yoga. For example, today I started my day at 8:30. I'm ending my day at 8 o'clock, right? So I'm also not doing the correct thing, right? So I hardly have any time to exercise. Morning, maybe I did half an hour of walk, and maybe I do another half an hour at night, but that's not sufficient. I've already spent 8 to 10 hours in front of computer. So I've been sitting here and seeing patients from morning till evening. So I think, sir, we as clinicians also should take care of our health. I think, even I am looking forward that I also incorporate more of healthy measures in my diet and in my lifestyle, and also to look into how we can reduce stress and how we manage work-life balance. That is extremely important.
Very, very, very important point. So this is what I have studied, and probably I think it's important for all of us to assess what is the duration of inactivity in order for you to see that change on the weighing scale. I think that's an important metric all of us should know. For me, it takes me exactly 2.5 to 3 weeks of being completely inactive. So, or taking the wrong kind of diet. After that 2.5 period, if I don't set things right, then that weight is going to stay back in me. So each one of us have that level of metabolism. I think we need to be aware of what our stress factors are. We need to be taking a look at our eating time as well. I think skipping meals, having too much of a gap between major meals, and having a stressful day, these are the wrong combinations, especially for us as doctors, to deal with this challenge. So it was amazing talk, madam. Thank you, Anusha, madam, for
Just
walking us
last
through.
point, how we can reduce as clinicians our sedentary sitting habit. Like for example, we are mostly to the computer, sir. You know that we are using some software. We have to enter all the data. So we can do one thing in between patient. Every patient goes out, we can accompany them and lead them, to the door, so that it's a courtesy for the patient. It's also exercise. A lot of my patients
Correct.
telling me, "Madam, why are you getting out from your cabin every time, when a patient comes out?" I like, it's two things. One is it's a courtesy for you. It's also going to be a good exercise for me. So easily, if I see around 50 patients per day, so I'm getting up 50 times and going up and coming. It is like maybe 50 meters also is important. 20 to 30 meters also is important. So that
So
way.
it's amazing. I think that's a very, very important tip for all of us. They say sitting is the new smoking. So, and
Correct.
so it's
Correct.
important. It's important for us to get up and move. And the way you have put it, linking it makes a difference to your patients. Yeah, they feel
Correct.
they feel touched that you're doing something, but also you're improving your health. So health can also have other side benefits as well. So this is
Yes.
a
Yes.
great point that you made, Dr. Anisha. And thank
Yes.
you so much